The best way you can possibly treat hypoxia is to correct the underlying cause. Work out what is causing the hypoxia and correct it. So, for example, we need to have a clear airway and we need to treat chest injuries. Remember, these were the causes of extrinsic hypoxia. We need to treat lung disease because that was the cause of pulmonary hypoxia. Doesn't matter what the lung disease is, work out what it is, work out how to treat that specific disease. If the patient's got pneumonia, give them the antibiotics, treat the infection, treat the underlying cause of the hypoxia. It could be that the patient is anemic. Again, it doesn't matter what the cause of the anemia is, but work out what the cause of the anemia is and treat it. Give them iron, give them liver to eat, give them vitamin B12, whatever it needs to treat the underlying cause of the problem. In this case, to treat the underlying anemic hypoxia. It could be that we need to improve the circulation because the patient has stagnant hypoxia. Are they shocked? Okay, give them intravenous fluids. Have they got heart failure? Okay, give them drugs to treat the heart failure. Treat the underlying cause. Do they have a histotic hypoxia? Fairly rare, but it does occur. Do we need to give them vitamin Bs? Whatever it is to treat the histotic hypoxia. Work out what's causing it, and if it's possible, treat the underlying cause, and then of course, because you've treated the underlying cause, the hypoxia will go away. Of course, if patients are hypoxic, they're going to benefit from oxygen therapy to improve blood oxygen saturations. And anyone who's suffering from an illness, doesn't matter too much what the illness is really, we should be aiming for target saturations of 94 to 98%. So if they're falling below those ranges, turn the oxygen up. If they're at the top of that range all the time, 98, 99%, turn the oxygen down. So it's not too hard really to work out how much oxygen is required if we go for these target saturations of 94 to 98%. However, if someone is a chronic carbon dioxide retainer, for example, if they've got chronic obstructive pulmonary disease, if they've got a neuromuscular disorder, if they've got a chest wall deformity, if they've got long-term cystic fibrosis, even if they've got morbid obesity, they might be retaining carbon dioxide. And in patients that are chronic carbon dioxide retainers, the initial target should be to aim for oxygen saturations of 88 to 92%. That is the initial management before we do blood gases and can titrate it more accurately. So most people in any form of illness aim for 94 to 98% saturations. Chronic carbon dioxide retainers will accept 88 to 92% saturations. Sometimes we can use adjunct airways. Of course, there's many of these. There's nasopharyngeal airways, oral airways, laryngeal masks, endotracheal tubes. You've just got to decide, using your clinical judgment, what the patient needs at that time. But a general principle in hypoxic patients is that they should be managed sitting up as far as possible. When someone is sitting up, the ventilation of the lungs is greater than when they're lying down. They get more air in. The bronchial passages are more dilated. So sometimes you can have a patient with low oxygen saturations who's slumped forward or lying flat, and all you need to do is sit them up. And the mere act of sitting them up into the upright position, where they can breathe much better, improve ventilation, that can improve oxygen saturations significantly. Such a simple intervention, as long as other things like their blood pressure and their general condition allow. Obviously, if they've got cervical injuries or back injuries, you'll have to use your initiative. Oxygen therapy, we've talked about aiming for these particular target saturations. Aids to ventilation, here we're talking about more mechanical processes of ventilation. For example, if someone's breathing spontaneously, we can use CPAP, continuous positive airway pressure. When I first used CPAP, we used to have these tight-fitting masks, and it helps to blow the air into the patient's lungs when they breathe in. These days we tend to use the hoods, whatever's fashionable, it doesn't matter too much, but there's positive airway pressure blowing the air in. The last resort, of course, for any patient is intermittent positive pressure ventilation. Such patients would need to be intubated, they need to have muscle relaxation, and of course they need to be adequately sedated. And in these patients, we want to give them PEEP, positive end expiratory pressure. That means there's a fairly high pressure, maybe 5 centimetres of water above normal. Additional pressure in the alveoli, which is blowing the oxygen through the walls of the alveoli, oxygenating the patient's blood. So oxygen therapy in various forms can improve blood oxygen saturations. I'm just reminding myself of the oxygen flux equation actually. Remember, oxygen flux is cardiac output multiplied by arterial oxygen saturations. So we've just talked about how we're going to improve the arterial oxygen saturations with oxygen. But alternatively, I can improve oxygen flux by increasing cardiac output. So one management strategy in hypoxia can be to look at cardiac output. So we can improve cardiac output. So if there's anything compromising cardiac output, we can address this. Treat cause of cardiovascular problem, whatever that is. So what is wrong with the heart? How can I correct what is wrong with the heart? Correct the underlying problem. If the patient is shocked, they're going to need intravenous fluids, very probably, especially if it's something like a hypovolemic shock. And as we mentioned before, the cause of hypoxia is congestive heart failure, and again that can be managed. So improving cardiac output will improve oxygen flux, because oxygen flux equals cardiac output multiplied by oxygen saturations. I'm just reminding myself of the oxygen flux equation actually, again. Oxygen flux equals cardiac output times arterial oxygen saturations times hemoglobin concentrations. The amount of hemoglobin in the red blood cells. And of course this is going to take time to build up, but let's look at how we can improve hemoglobin levels. Well, in an emergency situation, we're going to need blood transfusions. If a patient has lost a lot of blood, remember the red blood cells carry at least 98% of the amount of oxygen carried in the blood. So putting in colloids and fluid replacement eventually won't be enough. Yes, there'll be enough perfusing circulating volume to maintain blood pressure, but know that blood won't be carrying enough oxygen. So patients that have lost a lot of blood need the red blood cells put back. They need blood transfusions, emergency life-saving intervention. In the longer term, after trauma or after surgery, blood-forming foods are important. The best way to absorb iron actually is animal sources. Red meat, liver, although we don't give liver to pregnant women anymore. But for most people, animal sources are a good way to get iron. For people that are vegetarian or don't have access to animal protein, then vegetable iron is still very good, and it's absorbed much more efficiently if it's taken in combination with vitamin C. So if you can eat some green vegetables which contain iron, and eat some oranges with that as well, then the vitamin C in the oranges will increase the efficiency with which the iron is absorbed from those vegetable sources. Vitamin B12, of course, is essential for red blood cell maturation, as we looked at, as is folic acid. And some patients, we give this to patients with renal failure, benefit from giving erythropoietin injections, EPO injections. All of these things can improve the amounts of hemoglobin in the blood, therefore improve the oxygen flux. We're thinking now about the indications for oxygen therapy. When is oxygen therapy appropriate? And first of all, let's think about when it's appropriate to give oxygen in high concentrations. And what we mean by high concentrations is 15 litres of oxygen per minute. And this should be given until the target saturations are reached. And we've just talked about target saturations. Give 15 litres a minute until we get to these levels of oxygenation. Then they need to be maintained. So high concentrations, cardiac arrest situation, get as much oxygen into the patient as you can. Shocked patients need high concentrations. Patients that are very septic. Patients with major trauma need high concentrations in order to maintain target saturations. Head injury patients, of course, for reasons we've looked at on this video and other videos, it's very important to keep them well oxygenated. Because if they're not well oxygenated, you're going to get cerebrovascular vasodilation, which is the last thing we want in head injuries. Near drowning, patients that have been taken out of the water, as we've said, always try and resuscitate them. It's probably just spasm of the vocal cords. Give them high concentration of oxygen and you might have a perfectly healthy patient back again. Anaphylaxis, the extreme allergic reactions, they might need very high concentrations of oxygen because of the upper airway edema and the bronchoconstriction which occurs in anaphylaxis. Major pulmonary hemorrhage, and of course carbon monoxide poisoning. The high concentrations of oxygen here can help to blow off some of the carbon dioxide from the hemoglobin. So a few indications there for oxygen at high concentrations. So as always, remember we're looking for target oxygen saturations of 94 to 98%, unless the patient is a chronic carbon dioxide retainer. So that's what we're looking for. So some patients require moderate concentrations of oxygen, and let's say moderate concentrations are 10 to 50 litres of oxygen per minute. Aiming for these saturations. Undiagnosed hypoxemia is low blood levels of oxygen in the blood for an unknown reason. In that case, these patients might require 10 to 15 litres per minute to maintain these target saturations. Patients with acute asthma, if possible, use a rebreather bag and give them high concentrations of oxygen, aiming for these sorts of levels. Pneumonia, where there's consolidation in the lung, again we're aiming for 94 to 98%, where it might be necessary to give 10 to 15 litres per minute. Lung cancer, of course, can cause all sorts of anatomical problems in the lungs, blocking up bronchial passages and causing areas of consolidation, all sorts of problems. Post-operative breathlessness. Giving oxygen in this situation also helps the patient to blow out the any anaesthetic gases which are left over, which is good. Acute heart failure situations, giving moderate concentrations. Pulmonary embolism. Pleural effusions. Might be a malignant pleural effusion, for example, where there's a hydrothorax, fluid collecting between the pleural membranes. Pneumothorax, air of course in the pleural membranes. I suppose you could include hemopneumothorax there as well. Interstitial lung diseases. Severe anemia, if it's very severe you might need oxygen. And sickle cell crisis if you're working with patients who suffer from this very unfortunate condition. Let's think of a few examples where it's appropriate to give much lower concentrations of oxygen. Chronic obstructive pulmonary disease, long-term oxygen therapy, of course, significantly improves the prognosis. The more time in the day the patient can carry on breathing moderately increased levels of oxygen, the less likely they are to develop right-sided heart failure. Long-term oxygen therapy. Exacerbations of cystic fibrosis might need low concentrations. Chronic neuromuscular disorders where there's not adequate ventilation for neuromuscular reasons motor neuron disease, myasthenic disease, myasthenia gravis, chronic neurological disorders and muscular disorders. And even some patients with morbid obesity who just find it very difficult to, again, can benefit from low concentrations of oxygen, often over a prolonged period of time.